If you really see, when we actually talk about what Dr. Das was initially asking about the choice, the ketorolac and piroxicam are the two most notorious agents which are notorious for producing and inducing GI bleed. So keeping this thing in background and keeping in background the renal profile which can happen, the cardiovascular, the 9th July FDA guidelines for NSAID, they very clearly highlight that the increased tendency for MI, increased tendency for stroke, following any kind of NSAID. They have not specified which particular non-steroidal anti-inflammatory drug. And they also say that it can happen right in the first week. This is the guidelines which came on 9th of July. Right in the first week this can happen. And the more prolonged the duration it is for the use of NSAIDs, the higher chances are there, almost to the extent of 2 or 3 times.
NSAIDs can be dangerous even for the shorter period.
Even for the shorter period. So they say even in the first week, that's one. But if the patient has a past history of MI or those kind of things, then again the risk is almost 2 or 3 times more. And if you higher the dose, more the chances of these things happening.
So keeping this in mind, what is the role of opioids in this situation?
Yes. Now in the last 5 years, that's a very good question. In the last 5 years, so much of research has gone into the use of opioids, both in nociceptive and neuropathic pain. They have seen, now before that I would like to add, like what we were talking about osteoarthritis, we all talk about NSAIDs. There's a substantial body of evidence now to suggest the important role played by duloxetine. Imagine there are serotonin, norepinephrine reuptake inhibitors in the management of osteoarthritis, knee pain, and also even amitriptyline. There are studies which have recently come in the last 5 years. Now opioids, when we are talking of the chronic non-malignant pain and chronic malignant pain, everyone knows about cancer pain, so I'll not touch upon it. But in the non-malignant pain, there is an emerging role of opioids. And that's simply because when we actually talk about the whole modulation happening at different levels, and they have seen, because higher, when Dr. Durija was talking about sensitization, the things happening right up to the periaqueductal gray matter, right up to the rostroventromedial, medulla. When you see things happening at the level of the descending pathway and with the facilitation and the inhibitory process, so there is an upcoming role of opioids which has been seen. See, even in neuropathic pain, in the last conference which was there, in the neuropathic NEUPSICH conference in May, which was there at Nice, France, there were at least 10 studies in favor and convincing evidence being submitted for the role of opioids in the management of chronic neuropathic pain.
That means earlier we used to think that the opioids is most helpful for the nociceptive pain, but now it is changing that it is also helpful for the neuropathic pain as well. So it can be considered instead of the NSAIDs and the other medications. I'll be taking the opinion of the House that what is your opinion regarding the pharmacological approaches when you are treating the patient's pain? How would be deciding the drugs? What should be the fast drug and what are the different kinds of drugs in the different situations and how to choose those drugs? So any opinion from the whatever you have discussed here, we emphasize that the NSAIDs can be dangerous. Even for the shorter period it can be dangerous. We should not be ignoring the sensitization part. We should be choosing the drugs which is effective on the neuropathic pain. And from the beginning we should be starting those kind of drugs. Even from the beginning we can be considering the opioids. What is the opinion of the House? Any more further comments on that, the pharmacological approaches when you are treating a patient suffering from chronic pain, particularly of the degenerative conditions? Any opinion from the House? Microphone please.
Namaskar sir. I am from Cox's Bazar, Bangladesh, Dr. Vidhan Pal. I am an anesthesiologist. It's my privilege to take the opportunity, but I would like to say I draw attention especially for the anesthesiologist here. I am a new participant in such type of conference, and I have learned many things about chronic pain and many sorts of components. But as an anesthesiologist, acute pain is my first priority, and I think that acute pain is the mother of all chronic pain. So for the post-operative, especially operative pain, we should take care in duly and timely for the acute pain management.
Definitely, there are lots of papers which is telling that the acute pain is the source of the chronic pain.
But sir, I would like to draw attention for anesthesiologists, especially on the learned dais, that still now I feel that pain management, post-operative pain management is not in our hand. We are not practicing. Just doing the anesthesia in the OD.
It's a very valid point, but
Yes.
let us we are diverting to the other discussion point.
Yes, sir. Just I throw the question especially for the Dureza sir, and what should we do, and what will be the holistic approach for the pain management in post-operative pain starting from
That is completely
Thank
different
you, sir.
issues. We had the post-operative pain management topics. So let us concentrate on what we are discussing. That if we are seeing some patients, what should be the pharmacological approach? What should be, it can be including the acute pain as well. Pharmacological approaches, yes. Should we address whether be it a chronic, be it an acute, what should be the first line management and what are the drugs, whether we should be adding the anti-neuropathic medication from the beginning. So what should be our approach?
We spoke of the NSAIDs, we spoke of the opioids, we spoke of the alpha-2 delta ligands. What are the role of counter-irritants or ointments? Sometimes, most of the people they do that, give that, and also lidocaine patch. It was available and it was taken out from market for chronic pain.
See, the role of counter-irritants and gels and all, there is no evidence as yet whether they work. Even if you have these nanotechnologies-based ointments and all, there is no absorption and they have absolutely no role except for a placebo role. When you talk about Lidoderm, that yes, definitely Lidoderm and capsaicin patches are the only one which are very effective, and particularly in patients with post-hepatic neuralgia, in patients with allodynia, they are the most effective ones. So Lidoderm patches, not the one which were made in our country, but one which is made by Astra, and capsaicin, which is still not available. Very high concentration of capsaicin. They are very, very effective in localized neurologic pains like post-hepatic neuralgia. Otherwise, gels and all, no evidence.
Okay, Dr. Vyas want to make some comments on the opioids which was we was discussing.
He wants to say something, then I'll say it.
Good morning, sir. I am from Next Hospital, Bedford. Myself, Dr. Vicky Jaiswal. I want to just ask a simple thing that whenever we see the patient, we are not the first one. We are almost 5th to 10th, and the patient has already received many NSAIDs for a different period of intervals at like 1 month, 2 months, or even years. So we have to change the, we have to ask for the history of the treatment history, that how long he has taken the medication and what is the effect on his kidneys and
Definitely. The other aspects which should be added into the evaluation part.
Can I just answer you?
Yes.
In pain practice, once you are in a private pain practice, you will be the first one. If you have a pain center, any patient with pain of 2 days will also walk in. So you have to be a very good clinician to help those patients. NSAIDs have a role. Only in a hospital-based practice you will be referred patients who are not getting any relief. But in a real pain practice, you will be the first contact person where the patient with any pain will come to you.
Yes, I also want to add that thing, that many times we feel that this patient has been treated conservatively for so many years, so probably all the drugs has been exhausted. But in reality, it might not be true. We might be thinking that the very important drugs addressing the neuropathy sensitization has been missed. So if we are changing the approach by the pharmacological, the drugs only, we can have a very good response. But as a whole, as you are true very much, sometimes the drug has been, we are coming to that point when we should be thinking beyond pharmacological management. I am coming to that discussion later. Doctor, please.
So when a patient comes with pain, and along with drugs, you can get some advice to change their.
Okay, well, already I have discussed that part. That means non-pharmacological approaches should be added before we start the pharmacological. We have discussed that point.
The
Please.
point I wanted to make about opioids in non-malignant pain is, if it comes to non-malignant pains, I would rather avoid opioids. I would go for an intervention, and if that intervention still leaves the patient with pain, I will go for opioids, because we have a lesson to learn from the American experience, where they have very generously used opioids for non-malignant pains. And there are several articles by Dr. Jane Ballantyne which draw the attention to the risk of opioids causing opioid hyperalgesia and other problems. And God forbid, if these patients were to ever get cancer or some such thing, then they become practically untreatable with opioids in those conditions. So she is cautioning against the use of opioids, generous use of opioids. So I would say, in non-malignant pain, opioid is my last choice. I do use in several
Okay, we'll be
patients,
discussing
but it's
to
a
this
last
point that
choice.
when we should think of the intervention. Before that, Dr. Harshi wanted to say something.
I am Dr. Jahid from physical medicine and rehab background. I am a physiatrist. You have want to know chronic degenerative pain. Okay.
That was a kind of example. We just
Yes,
wanted to say
yes.
that what to do that.
we just go fast lifestyle modification.
We have discussed that part. Yes, it's very important.
Step product.
Yes, yes.
Then exercise. Then some physical, we apply physical agents. Then medication, then needling. Just five
Exactly, we
steps.
have discussed this thing that before we are starting the pharmacotherapy, before we are thinking of the interventions, we must be exploring the non-pharmacological options to modulate the pain. Dr. Harshi, please. We cannot take more questions. Yes.
Abdurrahim Rawami from Egypt. I think that intervention in chronic pain is not taking its role, its actual role, because it is the most effective, and we should start with it. And the reverse pyramid of the RESP is reversed and must be allowed to be in a correct position. That intervention, once we can do it, we must do it early, especially in cancer pain. Only medication for the chronic generalized pain in which we cannot do any intervention. But pharmacology must be after intervention, should be. This from our experience in Egypt. Thank you.
Dr. Harshi, please.
Yeah. So I would like to request the panelists to guide the audience about one thing. We know that whenever there is an inflammation, anti-inflammatory plays the role. That is why in acute pain, we generally use NSAIDs. When it comes to chronic pain, it is the hypersensitization, which is the major game. And that is why we use tramadol, paracetamol, which has got more effect at the spinal and central level to reduce the sensitization. All right. But the companies and pharma companies, they come up with, these patients have chronic inflammation, and so the NSAIDs have to be given longer, and the people are giving NSAIDs in chronic pain for a long period of time. That is one issue. And buprenorphine patch, people are claiming that they are advocating it for osteoarthritis pain. And now, as far as even tramadol is concerned, I have seen in geriatric age group, I give half Ultracet TDS. Even then, they might get illness. And now we are talking about buprenorphine patch. Of course, the release is slow, the quantum is low. Is it advisable? So, the use of the patches in chronic nociceptive pain, number one, and the NSAIDs for so-called chronic inflammation. What is the real story?
Before Dr. Duraja is starting, I just mentioning in the first part that I earlier used to think that the sensitizations takes place in the chronic pain, but this is not true. There are lots of experiments that even in the volunteers, there is very good articles published in the pain journal that the volunteers, the capsaicin injection